I'm Megan Cole Brahim. I am an associate professor and division director in the Division of Health Policy and Insurance Research within the Department of Population Medicine at Harvard Medical School. Really, the goal of our study was to look at trends in pediatric primary care mental health use over time. So we did this using about 10 years of administrative data, where we found that over a 10-year period from 2014 through 2023, we saw steady year-over-year increases in the extent to which mental health-related needs were presenting within pediatric primary care, where we really saw those increases particularly take off subsequent to the pandemic, although they predated the pandemic as well. And then for anxiety specifically is where we really saw the largest absolute increases, nearly a 300% increase. And overall, we found that ADHD remained the most common type of mental health related need presenting in pediatric primary care visits. So what our data really show are that pediatricians are increasingly seeing mental health needs come up during primary care visits, with well over 1 in 10 visits now including a mental health diagnosis as part of that visit. And kind of your question is, well, kind of why is this? And our data don't directly answer this question, but really a lot of other data suggest there are two main drivers. So one, I think we have a real increase in symptoms over time, and I can say a little bit more about what's driving that. And then on the other end, I think this explains our results to a lesser extent, but we're also seeing increases in screening for anxiety and mental health related needs over time that may improve detection. So when we think about kind of what's driving these increases in symptoms, I think a lot of other research has shown that things like exposure to social media, constant access to screens and digital technology, as well as some increasing academic pressures put on children and adolescents are really driving some of these symptoms. We also know that the COVID-19 pandemic exacerbated a lot of underlying mental health related symptoms. And while we don't show this in this paper, what we find is that a lot of the increases in mental health related visits, especially anxiety, are largely concentrated among the teen population, and that's the population that's really most exposed to some of these drivers that I mentioned. And at the same time, we also know that research has suggested that over the last decade, we've also gotten better at screening for anxiety and other mental health related needs during pediatric primary care visits. So while that does not explain the totality of what we see, it may explain some of the increase. And to that extent, that's a good thing. Sure. So I think some of the drivers that are bringing this into the doors of the primary care setting include things that I had mentioned, like social media use, smartphones, increased competitive pressures, COVID-19 related disruptions, really impacting everything, but especially anxiety. And I think the trends that we see in primary care are to some extent mirrored in the trends that we see more broadly across the healthcare system. But for a lot of kids, primary care is really the first and sometimes the only point of contact with the healthcare system. So it's really in these settings that some of these issues may be brought up either by the child or by a family member, sometimes for the first time. Sure. So it's a good question. And I think one of the most important approaches to having a pediatric model that really screens for and addresses a broad spectrum of mental, behavioral, developmental, and other chronic conditions. And that includes things like ADHD, depression, anxiety is kind of a starting point. And I think really kind of building on that, once an issue might be identified through a screening tool that may screen for multiple things at once, I think typical primary care physicians often don't always have the training or the time or the resources to then address all of those needs within the short span of a visit. So I think for that reason, there's really a real need to equip pediatric primary care practices with training, with staffing, with resources that really expand their capacity to effectively and really comprehensively address all of these needs that one PCP can't address in the 10 minutes that they have with a child. So that includes not just training for PCPs, but also often directly embedding additional staff like behavioral health clinicians directly into those primary care teams to really expand the capacity and ability for primary care to really address all of these competing needs for a child or for an adolescent. So a great question. And I think just to kind of step back, I think it's important to remember that nearly every child has access to a primary care physician, not everyone, but most. And at the same time, most children have a very hard time accessing specialty mental health care. So taken together with the fact that our data show that a lot of these mental health issues are presenting frequently in primary care, it really motivates the need to increasingly integrate these services into pediatric primary care. Easier said than done. And I think when it comes to integrated behavioral health models, they really come in lots of shapes and sizes and exist on a spectrum from somewhat limited integration, minimal staffing, maybe co-location of services, which isn't true integration, all the way through to full integration embedded within the primary care team, full staffing to support that team. And even across that spectrum, we often have different integrated behavioral health models that focus on different subpopulations. So for example, some focus on age birth through 3 years. Others may focus on kind of the full lifespan from birth all the way through adolescence. Others may focus more narrowly on certain presenting issues like depression and anxiety, whereas others are more holistic. So I think ideally what we have are really more opportunities and supports for behavioral health integration at that far end, where we have models that are addressing needs from birth through young adulthood. They're really comprehensive in thinking about all different kinds of presenting issues, not just a limited set of diagnoses. And I think to kind of your question about, well, kind of what does this look like in the real world? Well, we've implemented these kinds of models in a number of settings, including lower resource settings like community health centers, for instance. And really upfront, I do think part of it is ensuring that practices are well equipped with resources or funding to really provide kind of the initial infrastructure. And that may require sometimes state or federal grant funding that allows that. It may require philanthropic funding. And then over time, in order to actually sustain those models, it's important that we also have policies and reimbursement models that allow for the staff that are really critical to that care model to bill for their time. And this is especially important for smaller practices that really can't just absorb those costs of those staff. They have to be able to bill insurers for their time. And a lot of that takes policy to ensure that those roles can continue to be reimbursed across the board.